Hi, you're listening to my podcast, Colin in Conversation. I'm Colin. I'm a comedian, writer and broadcaster, and over the next few pods, we're going to be talking to the famous, the infamous and the fabulous. You're going to love this content, folks. You're going to want to comment, review, like, and anything less than a 5-star review, I'll consider a hate crime. But enough of me, here's some more of me, with a cool guest. Welcome to Colin in Conversation, where we interview the infamous, the famous and the fabulous. Today's guest definitely comes under the category fabulous. Welcome to the show, Dr. Karen Worth. How are you?
Hello, hi, good. Thank you. Thank you for inviting me along.
It's all right, and we endeavour to talk to people that... This is a bit self-indulgent for me, Karen. I decided I was going to talk to people that I wanted to talk to in the hope that people out there will find it interesting. So you're a GP?
Yep.
And how many years did you grace the NHS with your work?
Okay, so let me just work it out. 35 years.
Wow.
35 years I was working for the
That's
NHS.
service, isn't it? That's service. And what made you decide to be a doctor, Karen? Because I've got friends that have got stories, and as to why they did it. What was the reason?
Well, in all honesty, my dad was a GP, and his dad before him, and uncles on all sides. I mean, I didn't know my wider family. It's another whole story. They were killed in the Holocaust. But my dad was a really committed GP in the East End of London, and he absolutely loved his job. And he used to come home at night and regale us over the dinner table with stories of people that he'd met, and and he always felt he was making a difference in the world and doing something important. And I guess that rubbed off on me. Yeah. And I always thought, well, if I loved my job even half as much as he does, then it would be a good career to have. And I actually think it's probably true. I did love my job about half as much as his. I did love it, but I wasn't quite as passionate and committed as he always was. Yeah. But it was a really good, it has been a really good career to have. And it is a very special and privileged position to be a GP. Yeah. But undoubtedly over these years, it has become so much tougher. So, when I look back and think about the job that my dad did as a GP compared to what we now do, I mean, it's an entirely different role.
So what era are we talking when your dad was working? So
he stopped working in the 80s.
Yeah. Okay.
So, he was working from, the 60s till the late 80s, really. Well, in fact, he died in 91. So until then, and I qualified in 1988. So I've been a doctor since then. I did retire from frontline general practice nearly 2 years ago, but I am still working for the NHS, just in different sorts of roles.
Yeah. And so your dad was very much, because I was born in 78, right? Mm-hmm. So I'm probably one of the last generations of kids that can remember having a family doctor, a cradle to grave doctor. You had I had the same doctor that my mum had, my dad had, my brother had, and if he wasn't available, you got an appointment for when he was.
Yeah.
And there was none of this, so your dad was very much in that. How did that change for you? How did that, because that's very much changed since you started, hasn't it? The idea of one doctor for a family.
Yeah, it has changed, and yet there are still pockets of that, because that is very much the vision that I had of what being a doctor was. And I mean, I worked in 2 main practices through my career, so each place for 12 years or so as a GP partner, one in Radford in inner city Nottingham, and another one in Sherwood, which is still in the city, but a much more mixed kind of population.
Very different, aren't they? Sherwood, Radford, same city, very different problems.
Very, very different, yeah. But in each of those, I would say, I am probably a bit of an old-fashioned GP myself, even though I worked in a very different era. But, I would still say in small practices, you still can get that family doctor thing where people, you have a one-to-one relationship. And I mean, I also teach medical students, and we talk about, that actually continuity of care
Yeah.
in primary care is a really, really important aspect, that you get to know patients and patients get to know you and they trust you, and you build those relationships over a period of time. Obviously, there may be times when they need to see another doctor, but
Yeah.
essentially,
Yeah.
you have your one doctor. But it is true, it may not be cradle to grave. The longest I worked in one place was 12 years,
Yeah.
but that still is a pretty good chunk of time to get to know people. But I mean, I know doctors in the city, who I trained with, who did work in the same practice for the whole
Yeah.
30 odd years of their career. So it does still exist. What is currently happening is that there is more and more of a push to these bigger conglomerate sort of GP
Yeah.
practices, where you literally get an appointment with whoever is available. And because, clearly it's quite difficult to get GP appointments these
Yeah.
days, people will just take whatever is available.
I mean, that's what's happening out in the county. I mean, my mother is in a city, lives in Warsop, which is the other side of the county, and they used to have 4 doctors' practices for the area. It's now one with a variety of satellites.
Right.
So they have these little surgeries where, sort of Monday, Wednesday, Friday they'll be there, Tuesday, Thursday, and it's where do we start with that? Because if we go back to 97 when Blair came in, which is the last time I really think the NHS was on its knees, at the end of sort of Thatcher and the end of the 80s, there was a massive amount of investment, and it looked like a corner was turned to the layman. Is that a fair assessment? That sort of 90s into the 2000s, they threw some money at it. They tried to reorder some things. They bought in working tax credits, which helped the poorer people a little bit. It looked like it was kind of getting better out of the late 90s.
Yeah, I mean, having worked in the NHS and in primary care over the last 30 odd years, I've seen things go around in circles,
Okay.
The endless reorganization of things. Is hard when you're in an organization that, we had health authorities, we had primary care groups, we had, now we're, then we had CCGs, and now we're in the ICB, and all these different letters.
Yeah.
I mean, it's hard to keep on top of what they all mean, and are they beneficial? Are they moving forwards? I mean, in general, I would say, it's a difficult one. People are trying to make it better.
Yeah.
I'm definitely, all the reorganizations don't necessarily help.
Yeah.
And the clear fact is that there is not enough money going into the NHS, and primary care has been, year on year underfunded.
Yeah. Yeah.
To the extent now that, we are really on our knees, and, GPs, I'm sure that many people here think that GPs are paid really, really well, and obviously compared to most people, we have a good income, but actually compared to a lot of other professional people at the same sort of level, we're not.
But I mean, what people don't realise is, I don't know, my understanding of how a GP is paid in his practice is he'll get an allotted amount of money per patient, right? And that's regardless of whether they see you 500 times in a year or whether they never see you. And then you guys have to balance this. Can I just come back a bit, though? Because there was a discussion in the media a year or two ago where there was a discussion of handing the primary care budgets to the GPs because they were in a better place to see where the money was spent. Because I don't think always the problem is lack of money. From an outsider, it seems there's a lot of waste, and it's the way it's spent rather than how it's spent. And I don't know if you remember, but there was a discussion about handing the budgets to the GPs because they were in a better position to allocate where it should go locally.
Yeah, so we do have that to a certain extent. It's a small amount of the budget is given to the PCN, which is the primary care network, which is basically group of local GPs, and we decide kind of a little bit, but it's a small amount of money, really.
It's nothing compared to the budget.
Yeah, it is small amounts of money. It's complex. I mean, yes, how GPs are paid is extremely complex. You're right. The main bulk of the money is on the number of patients we have. So obviously there is a huge pull for practices to have more patients. However, we realize the more patients we have, the more work there is to do, and then the more staff we have to employ. So, that's one of the things that I don't think people realize, is that, GP practices are independent businesses. Now, I went to medical school to become a doctor, not to become a businesswoman, and my managerial and business skills are pretty rubbish, to be honest. And also I don't have the interest in it, but especially in a small practice, you end up having to do some of that
admin and all sorts,
so it's not just the per capita money that you get in. There are all sorts of other little pots of money. So you get money for doing this bit and that bit. And, if you teach medical students, you get a little bit extra. And if you take on this project or this research or this thing, you might get a little bit of extra money. And then what you have to pay out of that is the rent for your building, all your utilities, all your staff costs, a whole range of things. And then what is left at the end of the day is then the profit that is distributed amongst the GP partners. Now, there have been months when actually the GP partners, there's not enough money to pay us, or, is a really small amount of money. I mean, when in the small practice that I was in, we had real trouble recruiting new partners because nobody wants to take on a partnership when, all the responsibility is on your shoulders and very little of the gains, basically.
Which, of course, then means practices are taking on more locum doctors, which, of course, links us back into what we were talking about before, with making it impossible for a practice to provide you with a family doctor, because the only alternative they've got is to go through agencies or whatever, however it is you employ these locums. I assume it's agencies or something like that, So,
I mean, locums often are just sort of, local doctors who kind of, do the rounds, and, so it might be individual relationships you have. We never used agencies because they were just crazy expensive. But there are times when you might have had to, if somebody was suddenly off sick, for instance, and you were stuck. But otherwise you would try not to use locums. But more and more places are operating with salaried doctors. And certainly when I first qualified, the idea of becoming a partner was absolutely terrifying. And I thought, no, I just want to be salaried. Thank you very much. I just want.
I'll take my money. I'll go home. I won't worry about anything.
At the end of every month, and I'll do my work, and that's that. And actually, that is the direction that we're moving in. And, there are some things to be said for that. That's not a bad thing. But I think what the government and possibly the public hasn't understood is what amazing sort of service they get from GP partners, that basically we work incredibly hard over and above just the bare minimum, because they are, it's our businesses, and it's our,
and it's your house on the line if it goes
exactly. And it matters to us, we care about it. We are a bunch of individuals who are actually very, very, we're very hardworking and very caring. Yes, you get the stories once in a while of, these, ridiculous entrepreneurs who are earning 250,000 plus a year. I don't know who those GPs are because I don't know any of them. But, yes, for sure, there are a few people who are making a lot of money. Most of us, just make a reasonable living. And just on that, we had a salaried doctor who came to our practice and who did become a partner. And actually, she never earned more money than she had done when she was salaried. And she used to say, I'm not quite sure why I'm doing this, because she's had so much extra, more hours, more responsibility, more kind of stress, but actually no greater financial, incentive.
And it must be quite tough running a private company within a public sector. Do you know what I mean? Because there's not the capacity to find a new revenue stream. There's not, like if you're in the private sector and you make ice cream, for example, you can just whack another flavour in. But as a GP, you can't, I guess you could do private GP work if you wanted, but not within the confines of that surgery. You'd have to work somewhere
absolutely.
else, wouldn't you?
You can take on other jobs outside, and actually that is another thing. Most GPs have other jobs. I mean, I alongside being an ordinary jobbing GP, I also taught at medical school.
Yeah.
And I also ran a substance misuse clinic.
Yeah.
Not privately, that is also within the NHS, but it was a separate, so I worked part-time in my GP practice, but had other interests. And it's one of the things most GPs do, because to be honest, day in, day out, seeing patients at 10-minute intervals is absolutely exhausting. So we need to do other things to sort of, balance that.
And I'm going to come on to the drug stuff as well later, because that's something else that I've noticed. So many GPs have now, like I lived in Bournemouth for a long time, and they have a lot of drug misuse services based in Bournemouth, and a lot of it is GP led. A lot of it is little practices that have, and it's it's an extra revenue stream, but I'm sure it's a revenue stream that as GPs you'd rather not have. Because it's a drugs is something that's become far more prevalent. I would certainly, since you've become a doctor, I would say.
Sure.
That doctors are now having to, and chemists are now having to hand out methadone on a daily basis. They're having to deal with these daily things that there aren't extra funding for, are there? They're problems that we've been left with, and there's definitely an argument that the drug laws are archaic, but that's probably a discussion not to have with a GP, to have with an expert on drug stuff. But being in a city, there's a lot of that now, isn't there? There's a lot of heroin abuse and crack cocaine abuse, and it's caused another problem. And you could probably argue there should be a government body set up to deal with this. An NHS. We've got an NHS. We've got a social care system there. Is it epidemic?
There are all sorts of bodies that are looking at that, whether they're doing the right things, but that there are bodies who are.
I mean, would it be better to centralise it though, and deal with it? Is it a problem now? Is it a level now nationally where perhaps we need a central body to deal with the drug issue?
Well, I think there are some central bodies, but you're right that, it is then devolved locally to decide what the treatment services are going to look like. I mean, I'm obviously only involved in the treatment service angle. And so that will be done on a local level. And you're right, in some areas that is very much done in what we call shared care, which is, GP led. In Nottingham, we're very fortunate that we have a very good kind of central system as well, Nottingham Recovery Network, which also works in partnership with GP practices who also do some of the work. So actually I think we have reasonably all right treatment services.
Nottingham's a great trust as it goes. I think Nottingham's pretty good. Like I have an ADHD, I have neurodiverse issues, and I have a clinic. There's an ADHD clinic in Nottingham, which there isn't in a lot of other cities and a lot of other towns. And
so they have an incredibly long waiting list. If you're going to refer new people, we're talking about 2 years until they get seen.
Certainly for adults. Certainly for adults. How long did you train to be a GP? How long? Because we talked. You brushed over it earlier. You said you don't do it for the money. You know what I mean? Like you don't become a GP to take the crap that you guys take and to do the work that you do for the money. So just tell the listeners how long it took before you sat as a GP in your own right with nobody looking over your shoulder.
Okay, so it's 5 years at medical school. Then there's 2 years as a junior doctor in hospital now. When I did it, it was just 1, but now it's 2. And then there's another 3 years training as a registrar, a GP registrar, of which a year will be in general practice and 2 years in hospital. So those are all your training years. So essentially 10 years before you can then work as a salaried GP or a partner or a locum or whatever sort of other way you want to work as a GP. And going back to what I was saying before is more and more GPs we call ourselves portfolio GPs, which means we do all sorts of other bits and pieces and make up our working week from different things that we're interested in. And that could be a whole range of things.
And do you love the teaching? I
do. I mean, I've been teaching for 25 years and, yes, I do love it. My particular interest is teaching communication skills.
Okay.
Because doctors, we really, really need to be able to communicate well, listen well, explain things well, build relationships well. All of those things are really central to the role of being a doctor in all forms of all forms of medicine, not just general practice. Obviously.
That's good because, I always remember going back to the 80s, right? Doctors were a little bit more patronising and they were a little bit, they explained very well, but didn't often listen, so it's fun. It's interesting that you do that. And so in terms of communication, what do you think is there a Karen Worth golden rule that you give to the students that on day one you sit them down and is there a sort of golden rule?
Well, I think I think there isn't just one, because that's really sort of making it far too simplistic. It's actually quite complex, but also it's not. I mean, I would probably say be real with people, listen to people, and that it's a partnership, that thing that you were saying about, patronizing, paternalistic medicine, we're no longer in this phase where, we decide what's best for someone and we just, put it onto them. It has to be a shared process whereby, people are on board, because I can give out as many prescriptions as I like, but unless the person actually wants to take them and understands why they're taking them and is in agreement to take them, then my treatment plan is not going to go anywhere. So it's very much has to be a shared process, and so it's too complex an area to say one thing.
That's fine. That's
Those are some of the key elements, I would say.
Yeah, that's fair. You worked through COVID, Karen, didn't you? How was that?
I did.
How was that? Tell me about it, because we didn't hear much from you guys during lockdown. But I want to give, GPs shouldn't be in the firing line, but they often are because you're on the front line, and I imagine COVID was tough.
It was tough. I mean, our processes literally changed overnight. The government had been for a long time trying to push us to doing more online kind of consultations and telephone consultations. And most of us were like, no way. I didn't train for all these years just to be a sort of telephone GP. A call center GP, and yet overnight we had to do that. And as going back to the partnership thing, as a senior partner of the practice, I mean, I literally was reading policies and protocols, up until midnight every night, trying to work out, oh my goodness, what am I supposed to be doing here? How is this going to change, and what's safe and what isn't safe? We were also setting up, COVID centers for this, huge rush of people that we were expecting, that thankfully never happened. But, we set up, I mean, I wasn't directly involved with that, but I assisted in the background. But some of our GPs, went full out to setting up COVID centers. I mean, I did work at the COVID center several, for a while. And then obviously I got involved in the COVID vaccination program and worked at those centers. So, we were really, really busy. I mean, obviously, for a while, it all went really, really quiet. We weren't seeing anybody, but, pretty soon it became very busy, and we were, working, I got, a telephone headset, and, I'd be in my room talking to people, from morning till night, and trying to decide who was safe to just deal with on the telephone
Yeah.
and who we
I
absolutely
mean,
didn't need to see.
I can imagine that you had some ridiculous things. Like a friend of mine told a story about him having his dad having a consultation on Zoom for the first time, and he had an issue with piles, and he had a conversation with his son about how am I going to show him my bottom on the webcam, and I just imagined that it got really silly at points. You know that you know it was it difficult treating patients over the. I imagine it was. Do you feel
Really
like
difficult.
things were missed? Maybe not by
Well,
you, but
yeah, no, absolutely. And I think things did get missed and people did get, poorly treated. We all did our absolute best to try and remain as safe as we could. I mean, I would a little bit further on from that very first wave, we would get people down into the car park. I would go out. Remember one time it was absolutely
yeah,
pouring with rain, and we had to go out with an umbrella over me and be kind of like half hanging into this car, listening to someone's chest in their car because
yeah,
actually I needed to examine her rather than
yeah,
just say, I'll just treat you with this because, there are times you do need to examine people,
yeah,
and we would get people to send photographs in of this rash or this swelling, but absolutely not
yeah,
personal, genital areas
yeah.
so we would have to say, please do not send those photographs to us.
Because
Um,
because obviously the NHS's money seemed from where it was stood that for example the vaccine was given a limited budget. Was the same applied to you guys in general practice? Did they throw extra money at you to deal with the problem, or did they expect you to do it with the budgets you already had?
Yeah, we got a little bit of extra money, and particularly if our staff were off, because the main staff, the doctors and the nurse, in fact, I think it was only doctors, were off with COVID, then we would get
Yeah,
reimbursed for that, whereas we don't normally.
yeah,
So there was a little bit of extra funding, but not very much,
yeah,
really.
yeah. And so COVID was tough. We
It
came
was,
out of COVID, and you still were working in the noticeable after effects of COVID as a GP on the front line.
yeah.
There
I
must
mean,
have
I
been
think.
there must have been some that you noticed.
Yeah, I think people's mental health has been really, really, affected by COVID, and it still is. I mean, going back to the substance misuse thing, I mean, I'm now working in an inpatient detox sort of center, and what I'm noticing is that several people who are coming in for particularly alcohol detoxes, their drinking went up through the roof during COVID, and
Yeah,
has, for a lot of people, in fact, I was at a conference recently, and it showed that the increased amount of drinking that happened during COVID, it has not returned to the pre-COVID levels.
right.
So, basically, people's drinking has
Yeah,
increased. And with all the problems that goes along with
yeah.
people's anxiety levels, young people's mental health has been so,
Young
has been
people was
really,
going to be my next question because I've got a child that's 15 now, so her first few years at secondary school were, and she's autistic as well, and she was lucky in the respect her mum was a key worker, so she was able to go to school through, but she still suffered an incredible, like, there's a real mental health. You teach at university, so does my partner, and she says some of the students that have come over the last couple of years, it's been noticeable that they had that
yeah,
2 year
definitely.
hiatus.
They're not as used to socializing. They're not as confident being around people. They also have a much worse kind of attendance record. People just forever like, oh, I'm not coming, because they're just so used
I
to, oh,
watch
it
it online.
doesn't matter not going. We didn't go for, a couple of years and
Well,
we
I
were.
mean, when I did my degree, it was the tutors and lecturers were reluctant to post things online and on Moodle and on those kinds of things on the intranet systems because they knew ultimately it would affect attendance. And then COVID came along, and it was all 100% online. And I think you're struggling
to get people back. Yeah. I think that's really true. And I mean, it's all part of the move, sort of digital techno move anyway, that people are moving in that direction. But, definitely COVID really, entrenched that, particularly in young people's minds.
Did it hasten your retirement any, or were you retiring when you did?
No, definitely. I mean, I when I turned 60, well, in fact, just before I turned 60, I retired. I'd actually thought I was going to go till about 63, 64, because I can't get my state pension until I'm 67. I mean, I'm very fortunate, we're fortunate in the NHS that I was in that cohort that I could get my pension, my main pension at 60. But I had thought I would carry on the front line. But actually, I mean, and it isn't just, it wasn't down to just to COVID, but it's been tough in general practice. And actually, the endless GP bashing, there I was working so hard. So hard, and then to just be being slated at every corner. I just thought, what is the point? Why would I allow my physical and mental health to go down the pan when actually nobody is appreciating it? And that it might sound a little bit kind of
and how many of your colleagues do you think over the last 10 years, 15 years that you've worked with have actually thought bugger it and either left the profession or gone to the private sector or abroad where they're
quite a few. And I mean, I've got a WhatsApp group of people that were in my year at medical school, and so we're all turning 60, and so many of them are retiring, whereas most of us, I think, thought we would carry on for a bit longer. But it's just been like, well, what is the point? The NHS, it's tough. It's really tough. And we're just all thinking, actually, we'll stop and we'll do something else. But like I said, I haven't completely stopped working. People keep coming up to me going, oh, how's retirement? And I'm like, not really retired. I just left one job and started a different one. But the difference is that I'm working, I have so much less stress, so much less responsibility, and I can just go in and do a bit of work and then leave. And it is really different from frontline general practice.
So if you could sit down with Wes Streeting now, and you could tell him whatever you wanted to try and to fix the problem in general practice and in frontline healthcare, would you distill it to a couple of things?
It does need an injection of cash. It absolutely does. General practice does need more money. So that is probably the first thing. And I would say, think really carefully before you dismantle the current system of GP partnerships, because actually you get a really good deal out of GP partnerships. I mean, undoubtedly, it is very variable across the country. But if they, and I would say, move away from this idea of huge kind of conglomerates, because they're impersonal. People don't like working in them, and patients definitely don't like going to them. Some people do, working age people who just want an appointment at a convenient time. They don't actually care which GP they see. They just need an appointment for whatever it is. But anybody with mental health issues, older people, families, they want that personal interaction. And there are so many people, people with multiple disadvantage and, issues. They need the continuity of care. And so, moving away from that is not the answer. Yes, it might look cheaper and good on paper, but actually it's not what people want.
There's room for improvement, and throwing money at it is what successive governments seem to do. But is there an argument now for there being perhaps a one-size-all-fits-all healthcare system is not really appropriate now? For example, if you can afford to come out of the NHS, should you be made to? If you can afford to go private, to release the burden on the NHS? Is it something that legislation might help? If we said to people, look, if you can afford private healthcare, go and get private healthcare. We'll give you an NHS rebate. We'll give you a rebate on your national insurance. Whatever we need to do, just go and get private care. Would that alleviate the stress a little bit?
Then you'll have even more of a two-tier system. What I've always been really proud of in this country is that essentially we have, a service that provides for all at the point of need.
Okay.
And that's really, really important. No, I absolutely don't think that an expansion of the private healthcare system will be good. In fact, I hate the fact that so much of the NHS money is already being filtered off into the private healthcare system and has been for the last 15, 20 years.
Yeah, and I mean, I'm not suggesting for a second that we privatise the NHS. What I'm suggesting is, if you can afford to alleviate the NHS of the burden of your healthcare.
So who do you think is running the private healthcare? Who do you think is staffing the private healthcare? Except people who have been trained here and and are working there. So if all our consultants, all our GPs will be leaving and working there
in the private sector. You'll end up with an NHS that's staffed by students.
Exactly. So, more people who, they'll get better funding, they'll get paid better, they'll have better conditions. And, so people will go to work there if that's the main option. I
mean, you could see the disease I had with asking the question. It took me like a visit because I'm not comfortable with the idea of a two-tier system. But as somebody that's been waiting 18 months for somebody to have a look at my knee, I think that if I could afford to, I would just go and pay somebody to have a look at my bloody knee. There is no one solution. We've heard from you that it's very, very tough on the front line and that people are leaving the profession, and that can't be good for the NHS either,
No, it really isn't. And more people are leaving and practices are closing. A couple of practices in Nottingham that I know, really good practices, have closed down, or been taken over by a private company, just because, it's just too tough and too difficult. And, there's a whole generation of my generation of doctors who were the partners who are now coming up to retirement, and particularly some of them are all leaving at the same time. And then, they can't find the people who want to come in and take it over, because the responsibilities are just too big. So, when I say, don't let go of the partnership system, actually, it's happening because the system is so difficult to work within, then, it is going.
So they then just become limited companies, I guess.
Yeah, and
if they can't find the partners, then their only option is to become a limited company, isn't it?
Yeah, and in some situations, if they are well run and they are not necessarily doing it for profit, but most of Virgin Healthcare or whoever else, I won't name a whole load of people, but they're in it because they want to make money out of it. And we were never in it. We were in it to make our salaries, to feed our kids and our families, but we're not in it to make lots of money. It's tough.
You're also involved in a charity, aren't you, that feeds loads of people? Let's talk about that. Let's talk about something a bit more light-hearted for the last few minutes.
Well, I don't know that I'd say it was light-hearted. I mean, homelessness.
Well, it's a bit more. It's food.
Food, it is food, but basically,
and we all love food, don't we?
So it's called Salam Shalom Kitchen. It is a Jewish Muslim-run charity, which was set up to alleviate food poverty and reduce social isolation and loneliness. So we run a cafe-style environment once a week in Hyson Green, in a very deprived inner city part of Nottingham. And we've been running 10 years. We're having our 10th anniversary this year. And it's an amazing project. I'm hugely proud of it. I'm the Jewish co-chair of it, and have been doing so since the beginning. And we now have 100 people a week come
do you work with Sajid?
Yes.
Yeah, because I've got Sajid down to do an interview with me at a later date about some of the other stuff he does as well as the charity work as well. So in 10 years, and you're obviously, I don't need to ask you. I know what the economy's like. You'll be feeding more people than ever, I would imagine.
Absolutely. I mean, that went up massively during COVID. So during COVID,
how was that being done through COVID?
Yeah, so we closed for the first 3 months when there was the absolute lockdown, and then after that we continued. We used to make the food in a different venue and just serve it outside in takeaway boxes, so people would just come get their takeaway boxes, get some groceries, because we pick up tons of supermarket surplus every week. We have a whole network of drivers who go around different supermarkets. So we're also, a sustainable project, saving all this food from waste. And we cook up, 150 meals every week to people in need. Yeah. So, it's a great project. It works on so many different levels. The volunteers who come love it. It's a really friendly, sort of lovely environment, and the people who come to use it really need it.
Yeah.
And increasing numbers are needing it.
Yeah. And is it families? Is it adults, children? Is it a mix? Is it?
Yeah, it's a mix. So we have street homeless, we have people with substance misuse problems, asylum seekers and refugees, we have families on low income, we have older people who come maybe primarily for the company. We have lots of overseas immigrants. We have increasing number of students. So we have anybody, really. Yeah. We don't ask questions. We don't, there's no referral system. Anybody can come. So actually, often we don't necessarily know who's using our service, because it's a welcome to all. So anybody who walks in can have a meal and can go away with a bag of groceries.
Yeah, and it's obviously it's set up by the Jewish and the Muslim community as a kind of solidarity.
Exactly, yeah. Right. But it's really important, the Jewish Muslim partnership aspect of it, that we're working together and showing a different narrative, really, that we always say we're cousins and we work together. Cousins sometimes argue, but actually we're like family.
Oh, that's really nice. And if anybody wanted to donate or even come down and have a look, because obviously the podcast will go out nationally, but to Nottingham, if somebody wanted to come along, can they find out about that?
Yeah, so you could go to our website. You just put salamshalomkitchen.co.uk, and we've got a website. There's a donate button. We're always looking for donors. One-off or regular would be great. But yeah, absolutely, you can volunteer on there. You can come down, or you can just come down and have a look on a Wednesday afternoon. So at the moment, we're at the Bridge Centre, which is opposite Mary Potter Health Centre in Hyson Green. But we are shortly going to be moving to the Himmer Hub, which is near the tram stop in Forest Fields.
Okay. And a question that I ask all my guests, right? Because, final question, I really love sandwiches, Karen. My favourite food is sandwiches. I don't. If anyone asked me that question, so if I gave you 2 bits of bread, what's the perfect sandwich for Dr. Karen Worth?
I would say I like avocado. There is a really great deli in Sherwood that's a Turkish-Polish deli, does this great white Bulgarian sort of, Eastern European cheese. So I'd probably have that avocado, the white sort of salty cheese. It's a bit like feta, but nicer, creamier. And maybe some chili, a chili sort of jam in there. Maybe a bit of vegetables, maybe a bit of lettuce or cucumber.
It sounds all right, that does. I didn't see where you were going with it. And then when you said it was a white cheese, a bit more like feta,
but it's sort of soft and creamy. So avocado, that, chili, and then maybe a bit of lettuce or something. That would be great.
Nice. Nice. That sounds all right. Dr. Karen Worth, thank you very much for talking to me. And all your details and stuff, I'll put them in the bio for the podcast. So if people want to donate, or they just want to go down and check you guys out, or even give a bit of time, then all right, that's brilliant. Thank you very much.
Thank you very much.
Thank you for choosing my podcast from the plethora of podcasts available. Oh, yeah, if you want to find out more or hire me or, just say hello, you can find me on all social medias at Comic Colin 78. TikTok, Facebook, Instagram, all the others. Comic Colin 78. That's Comic Colin 78.
The Colin in Conversation podcast was presented by Colin Etches and edited and produced by Neil Long at neillong.com.